All right, so we have two speakers. The first speaker that we have is Darren Doramol, as you can see on the screen. Darren is a partner with an advisory firm called Venndelta. He has 15 years of experience in advisory and technical data modelling, specialising in health and human services sector. Darren is experienced across both qualitative and quantitative aspects of consulting projects, as well as strategic reviews, health planning, data analytics, and economic modelling. He's also a key member of the team delivering the Department of Health, Disability and Ageing project, which is one of the projects as part of the national platform for promotion of CQRs within the sector, and that project is called Mapping of Common Data Elements Captured in National CQRs. So I'm going to hand over to Darren now, and then he will be able to share his presentation, and then following that we will I'll introduce Scott Winch.
Thank you, Tamara, and good afternoon all. I'd also like to thank ACTA for the opportunity to present here today. So as Tamara mentioned, I'm a partner of Venndelta. For the benefit of those coming across Venndelta for the first time, we're a small consulting firm primarily working within the health, aged care and disability sectors. Our senior staff combined have over 50 years of consulting experience across data analytics, technical modelling, strategy development, and program review and design. For those registry staff that have participated in the study, many of you would have met Dean McKay, who is an Associate Director at Venndelta and is the lead consultant for this project. Over the course of the project, Dean was also supported by several Venndelta staff, including myself. Unfortunately, Dean is on leave this week, so he could not be here to present to you today, although I know he really wanted to. So as the title of this project suggests, Venndelta has been asked or tasked with mapping the common data elements captured in national CQRs. As shown on screen, the project aims are to better understand the current CQR landscape and obtain registry views on their level of interoperability readiness. Secondly, to identify priorities for application of standard data items across the CQR sector. And finally, to determine priorities for future development of standardised CQR data templates. The eventual aim is to translate these standardised data templates into HL7 FHIR profiles and have them incorporated into clinical systems for EMR vendors. So in order to meet these objectives, we delivered 5 main activities, which are listed under the project scope on the right of screen. The first activity was selecting and recruiting representative sample of CQRs to participate in the project. The second was collecting and collating information for each in-scope CQR on what data is collected, where the data comes from, and what standards are currently in place. The third activity was to identify the common data elements across CQRs and assess their level of uniformity. We then developed an initial set of CQR data elements that we thought would benefit most from the application of national standards. The final activity was to consult with CQRs to inform and help refine our final recommendations for data elements proposed for standardisation. Importantly, I think I'd like to point out that the scope of this project does not involve identifying variables that should be collected on a mandatory basis. So our recommendations do not seek to mandate or suggest mandating the collection of any variable by any registry. Our methodology involves 7 key steps to deliver this project, which is shown at the bottom of the screen. We're in the process of preparing our recommendations and final report, which will be presented to the department. Today, I'm going to be providing you an overview of what's likely to be contained in this final report, and we'll go through the key findings from each of the project steps. So the first deliverable and key to having a strong foundation for this project was recruiting an appropriate mix of registries to be involved in the study. From the onset, the department wanted to have representation of CQRs that were funded under the National CQR program, are identified as priorities on the Australian Register of Clinical Registries, are appropriate maturity to collect suitable data elements, And for that means being established prior to 2020, publish annual reports and provide data back to clinicians on a regular basis. And finally, having information readily available on data elements, such as published data dictionaries. So we aim to engage 30 CQRs to provide a representative sample across Australia, which would account for approximately 25% of the 123 priority CQRs. We felt that this would provide a sample that accounted for a broad range of registry types and characteristics. We implemented a stratified sampling approach, targeting an ideal profile of participating CQRs that was agreed upon between us and the department. The profile used 6 key dimensions, which are in the black arrows in the diagram on screen, and their corresponding targets are the green boxes to its right. So in terms of engaging with the sector, 4 tasks were undertaken to try and obtain a representative sample. In short, the EOI survey was distributed to the CQR sector. Responses were then assessed and CQRs were identified based on the ideal profile that was previously outlined. Selected CQRs were then notified and consultations were arranged. The key outcomes from this initial survey of CQRs are shown in the graphic on the right. So in summary, 37 individual registries responded to the survey, all of whom indicated that they were willing to participate in the study. 89% of registries reported using direct entry into their database, and 16 collected prems and proms. And in terms of interoperability readiness, 7 registries indicated that they were currently capable of using HL7 FHIR frameworks, of which only 1 reported to currently using FHIR standards. So this slide here provides an overview of the final sample chosen. In the end, the project ended up with 28 registries being selected to participate in the study. And although there were over 30 registries willing to participate, discussion with the department resulted in these 28 being selected, which reflected a profile that closely aligned to what was defined as the ideal profile or mix of registries. And once this sample was selected, the team then moved on to the core component of the project, which was identifying which CQR data element should be recommended for application of national standards. So steps 2 to 5 of our methodology, which is highlighted in green, were focused on identifying which data elements should be the highest priorities for standardization. So this involved a mix of qualitative research through consulting with CQRs on potential priorities and our own independent quantitative analysis. Both these processes were equally important to identifying the initial priorities for standardization. So as we spoke to registry staff, key themes started to emerge. These have been grouped into 3 main topics as highlighted on screen. As expected, there was quite a lot discussed with registries, and in the interest of time, I won't go through everything that's presented. However, there are some points that I think are important to highlight and played a key role in our understanding of how and what data elements should be standardized. As we consulted with more and more registries, we noted that there was a high variability of what data is collected and how that data is collected, from manual input into registry portals, paper-based forms, and in some cases, data extracts. Registries also noted that some of the data fields cannot and should not necessarily be standardized, as these fields were collected specifically for registries' purposes. In addition, not all fields are mandatory, and registries expressed a reluctance to enforce mandatory fields, particularly system rules. And importantly, registry staff generally acknowledge that there are benefits to greater interoperability, standardization, and linkage capabilities. And whilst they considered most things manageable, registries felt that this would not necessarily be an easy task, and its difficulty should not be underestimated. So along with this, there was also data-based challenges, as well as resourcing constraints from both the staff and funding perspective. A couple of challenges that were raised on this front was around the cost and resourcing requirements to make changes to both the system as well as historical data in a registry, and another around the timely process should ethics and governance approvals be required. So taking all these into consideration, most stakeholders suggested that patient demographics would be a sensible place to start for any form of standardisation. It was thought that this would be the most collected variables and likely to be the most standardised, which in theory would be less challenging for registries to implement. Other data elements that were deemed as being nice but possibly more complex and difficult to standardise included patient comorbidities, diagnoses, ethnicity, adverse events, and outcome and quality indicators. So the second component of identifying potential data elements for standardisation was our desktop research of all data elements collected by participating registries. To do this, a 5-step approach was used for analysing commonality and uniformity, which is presented on screen. So first, we obtained all data dictionaries and transferred them into a comprehensive and all-encompassing master database. The second step was for us to group data elements with common meaning and purpose. This was largely judgment-based, and as an example, in the instances where registries had date of birth, DOB, or patient birth date, we classified this into a common grouping called patient date of birth. The characteristics for each of the data elements were then reviewed and presented in a consistent manner so that they could be assessed for uniformity. But however, before getting to that, prior to any analysis being conducted, a uniformity measure was developed. So uniformity was measured against 4 key dimensions, that being whether data collected was in the same format, so for instance, numeric dates or strings, with the same maximum field length, using the same data set code sets, so for instance, 1 for yes, 2 for no, or vice versa, and where applicable, using the same unit of measure. And so an example of this would be years, months, or a combination of both when reporting age. And finally, the data elements captured by registries was then analysed for commonality and uniformity, which we will go through shortly. But in terms of the database compiled, it contained over 8,500 individual data elements, which is equivalent to approximately 305 per registry. Of this, 319 common groupings of data elements were identified. And by common, we mean that the data element was collected by 2 or more registries. And in contrast, just over 6,600 data elements were not common, or in other words, 78% of data elements were unique to a single registry. So this slide here provides our analysis on commonality of data elements. The diagram presents each common data element by the number of registries collecting that data element. So what you will note here is that there was not one single data element that was captured across all 28 participating registries, with the most common data item collected by 23 of them. Even when looking at the 20 or so % of data elements that are captured by more than one registry, it's evident that data captured by registries is quite diverse, with the majority of data elements being common to 5 or less CQRs. More specifically, only 29 data elements were common to 10 or more participating CQRs, and furthermore, only 14 were common to more than half the registries. Looking at the tail end of this diagram, you'll be able to see that more than half of the common data elements were collected by 3 or less registries. And in terms of our uniformity analysis, this was conducted on the top 35 data elements that were common to 9 or more registries. This has been presented on the table, which is on the screen on the right. So in this table, what you'll be able to see, and most importantly, that's consistent with registry views, is that patient demographics were the more common data element that was collected across all the registries involved. So this table and chart that's now presented details the uniformity score for the 35 most common data elements. The table on the right provides a heat map of the two criteria, while the scatter plot is also presenting the same information just in a chart form. So if you look at the scatter plot, I know that the data labels make the scatter plot a bit difficult to read, but what is clear is that there's only two data elements that have high commonality and uniformity, these being patient date of birth and patient postcode. In addition, you'll note that Medicare, whilst being less common, with 13 registries collecting this data, had the highest uniformity when it was collected. For this data element, the main difference in collection was around field length, with one registry having a field length of 10, another having 14, and the remaining having 11. So in the table on the right, you'll also note that some of the data elements have an asterisk marks against them. This asterisk signifies data elements that were included in our initial shortlist for potential standardization because they either had high commonality with moderate to high uniformity, moderate commonality with moderate to high uniformity, or with data elements that registry staff thought would be of high value. So for instance, patient diabetes status and some of the selected patient demographics. So this slide provides a summary, I guess, of the commonality and uniformity analysis combined with the learnings from our first round of consultations. And this resulted in 35 data elements being proposed as candidates for standardization. On this, there's a few things that I'd like to note, and I think it's quite important to note this. The priority areas were mainly based on data elements that were commonly captured across registries and where the impact of standardization appeared to be minimal. So these do not reflect any measure of importance relating to that data field itself. The other point is that this was very much a short list and was preliminary and was tested with registries for a second round of consultation. And as such, I don't think there's much point in going through each of the data elements shortlisted, but they're up on the screen for you to view. As an overview, though, I'll give you a brief idea of how these groupings were classified. So group 1 are data elements with high to moderate commonality and uniformity. Group 2 are those data elements with high to moderate commonality but lower uniformity than group 1. Here, registries viewed that these data elements as high value if standardized, but our analysis indicated that there was work that was required for these to have aligned code sets. Group 3 are data elements that have either moderate to high commonality or uniformity, but did not have both. And group 4 are data elements that were on the lower end of commonality and uniformity, but were viewed as potentially high value. This group also has 5 additional fields that didn't feature in the previously listed top 35 common data elements. And finally, there was several data elements that were common across cancer and critical care CQRs. But not to any other registry. Given the commonality within these registry groups, these were pulled out separately and presented in Group 5. This shortlist was presented to CQRs to obtain their views on whether the elements should be standardised, what efforts would be required to implement consistent data elements across the sector with these in mind, and other considerations that needed to be factored in. Okay, so this now brings us to our second round of consultations, which were completed with 25 of the participating CQRs. Consistent with earlier views raised, registries highlighted that standardized data elements should have high utility to registries. This was commonly defined as elements improving personal identification and data linkage, such as date of birth, name of patient, and postcode. Furthermore, data elements should be stable over time, for instance, sex at birth, and should be epidemiologically sound. In addition, the focus should be on those elements that are more commonly captured by registries and elements where national standards, such as media, already exist. Other more pointed feedback on specific data elements presented included that the risk prediction and clinical marker scores, such as ECOG scores, and creatine levels were considered lower importance to standardise, as they could be interpreted or used differently at different points in a patient journey. Registries indicated that hospital or location-specific variables would vary and have little value in standardisation. And if postcodes were to be standardised, registries suggested that this could be used to derive jurisdiction. In terms of the preferences for standardising data elements, registries suggested that date of birth was considered more important than age, sex was commonly considered more important than gender, and country of birth was more important and less complex than ethnicity. In terms of the implementation considerations, registries noted that improving data linkage is actually a high-value proposition, which may in turn be sufficient incentive to drive registry buy-in for standardisation. It was also noted that certain changes are considered easier than others to implement. For instance, changing code 99 other to 9 other or increasing character field lengths were generally considered straightforward. However, more difficult changes were things such as adding or changing code set values, and this would likely require registries to seek ethics approval. Another point that registries once again raised was that funding is needed to support any substantial system or historical data changes that are required. In addition, it was also suggested that registries already funded under the national program would be a good starting point to commence implementation. In terms of some of the broader issues raised, registries viewed that, although not currently captured by many CQRs, there were a number of registries that had an appetite to include IHIs, which would help standardise identifiable information and improve data linkage. Registries also expressed a degree of openness for government mandates to help drive standardisation, and although acknowledged to be of high value, there was no consensus on the best way to apply standards to patient conditions and comorbidities. So this is the final slide, and it combines all our learnings obtained during the course of the project and sums up our thinking around the possible candidates for standardisation in the near to medium term. In total, 14 variables are being put forward, many of which are patient demographics. There are also some other patient-specific details, including patient date of death, whether the patient is alive, admission and discharge date, as well as procedure date. The blue pillar shows that the 5 data elements that are already relatively common and or uniform and could be standardized with relatively low burden. The next 2 pillars show data elements that registries indicated would be of high value if standardized, but their lower levels of uniformity meant work would be required to achieve this. The teal pillar contains 2 data elements that would require simple alignment of code sets to be standardized, and the green pillar has 7 data elements with lower levels of uniformity and generally require more work to be standardized. So at this point, I'd like to reiterate the fact that what's being proposed here is as suitable candidates for standardization is not being recommended for mandatory collection. Rather, the thought is if these data elements are being collected, consideration should be given for these data elements to be collected in a standardized way, particularly if or when registries are considered changing or updating their data collection forms. You'll also note that the IHI has been included or highlighted as a key focus area. This is primarily given the interest in broadening, or the registry's interest in broadening the use of IHIs. And the thought here is that should IHIs be captured across more registries, consideration should be given to collecting these in a more standardized manner from its introduction. So this essentially is where we've gotten to with this project, and hopefully I've been able to provide a summary of the work that Venndelta has undertaken, as well as some of the key learnings that we've taken away. As mentioned earlier, we're in the process of preparing our final report and recommendations, and will largely reflect what's being presented today. Before I wrap up and hand back to Tamara, I've just put up our contact details for Dean and myself, should anybody have any questions or wish to discuss anything. Thank you.
Perfect. Thanks, Darren. Really appreciate that. We do have one question in the Q&A. If anybody else wants to add anything, the time is vital to do that now. We'll get to that question in a minute. I just as a couple of comments, because I guess we've acknowledged that there is a lot of variability that happens across registries, but I was a little bit surprised that there wasn't quite as many data variables or data fields that were the same, that we were all doing as a consistent thing. So I was a little bit surprised by that. My other comment also is, you didn't really mention the work around the standardisation of Meteor, although it was on your screen. It's certainly something that is part of the Australian framework guidance. So it is something that I think registries need to be thinking about. Certainly, if they're thinking about sort of self-assessment and compliance with the framework. So those are really just sort of two comments. I'm just going to come to that question. I don't know if you can see the question there, Darren, in the Q&A. So the question from Eliza is wanting to know what maturity framework you actually used around the selection criteria, and how it. We don't really have a maturity framework for CQRs here in Australia as yet. That is work that is currently being undertaken. So just wanting to know a little bit more. Eliza's like to know a little bit more about that, if you can.
Yeah, so essentially that maturity framework was something that was just discussed with the department in terms of how we could, I guess, get a representative sample. So acknowledging that there isn't a maturity framework currently, that was basically just based on the criteria of whether or not the registries were operational for some period of time, prems and proms were being potentially captured, whether or not data was being fed back to clinicians on a regular basis, and things along those lines. So that was essentially a criteria that was agreed upon between us and the department to just make sure that we had captured a broad range of registries that were representative of the sector.
Great. Thank you so much. Excellent. All right, now I'm going to introduce Scott Winch, who's the head of Aboriginal Health at the SAX Institute. Again, this is another project that is being supported by the National Platform for CQRs by the Department of Health. So Scott's leading this project. The project is around developing best practice guidance on embedding Indigenous data sovereignty and data governance principles. And it's something that, I guess I hear quite often is not something that we have moved into that area very well, or doing broadly across the registries. So just to introduce, as you can see there on the screen, Scott's got a PhD Aboriginal education. He's a master's of applied epidemiology, as well as a graduate diploma in health services management, and he's a proud Wurundjeri man. He's got 30 years experience in Indigenous affairs at local, state and national levels, and he's the previous Director of Indigenous Data Sovereignty at the New South Wales Coalition of Aboriginal Peak Organisations. And we probably couldn't get anybody more who knows this area as well as Scott. So thank you very much for joining us, Scott, and I'm going to hand over to you now.
Thanks very much, Tamara. And thanks, Darren, for that really insightful presentation. I took a fair bit out of that one. Thanks. I'm just going to share my screen and get it up and running. Sorry. All right. Start with acknowledgement. Yama Yamanda Marain Wudje, Yuanadi Scott Winch, Roger Gibber, Yunungu Yinamari Gadigal Nurumbu, Yunungu Yinamari Gadigal Mudigang, Dandu Wayu, Nandangu. So I just said, hello, hope you're all well. My name's Scott Winch. I'm a proud Wiradjuri man, and I'm acknowledging that I'm here on Gadigal country and acknowledging Gadigal elders, past and present. And these are important cultural protocols. As we do, we introduce who we are, who our mob is, and where we're from, our family groups. But also we acknowledge elders as our knowledge holders, and that's pretty pertinent in this space around Indigenous data sovereignty. These are traditional knowledge systems which are essentially digitised and have got strong cultural governance. As Tamara said, I'm the head of Aboriginal Health at the SAX Institute, and I've had a number of years' experience in the Indigenous data sovereignty space. So we've been commissioned to do the work around embedding Indigenous data sovereignty into a number of CQRs, and it's very important work for a number of reasons, but it's because there is currently a lack of appropriate governance across in First Nations governance in these CQRs. And as Darren's pointed out, there's actually a very low rate of Indigenous identification across these the CQRs, which is concerning given that First Nations populations are behind on most metrics around health equity. So Indigenous data sovereignty, and I guess there's kind of a couple of aspects to this, and Indigenous data sovereignty happens at a community level, and most of what we're doing is around governance of Indigenous data, not actually the Indigenous data sovereignty. So when the data gets held by communities, that's when Indigenous data sovereignty is enabled. And it's not just about justice and our rights, but it's also about trust, accountability, and it's also about community wellbeing and how we can really support the health endeavours of communities. So Indigenous data sovereignty is basically the right of Indigenous peoples to govern data about themselves. It's grounded in self-determination and is aligned with the United Nations Declaration of the Rights of Indigenous Peoples, which Australia is a signatory. And it sort of moves data governance from just being extractive to also empowering and enabling. So there's a long history of data being taken from communities, and really poor data repatriation, enabling communities to really benefit from those insights. So a number of key frameworks, and internationally we talk about the CARE principles, so it's collective benefit, authority, control, responsibility, and ethics, and that's kind of around how data sovereignty is positioned in communities. But there's also, we've got the Maori Wingara principles around Indigenous data sovereignty, and they're Australian-specific set of principles, and that's the data sovereignty aspects. And CARE principles are more around the operationalisation and the governance aspects of Indigenous data sovereignty. And there's obviously a number of other frameworks which are relevant, ethics frameworks. LeWitcher's got a toolkit, and the NIAA Governance of Indigenous Data Framework, which the Australian Public Services adopted. So, study overview. This is a partnership between the SAX Institute and Monash University and the Department of Health and Aged Care, and Monash obviously are custodians to a number of CQRs. And so we'll be developing a practical guide to embed Indigenous data sovereignty into 3 CQRs, which are held by Monash. These are cardiac, diabetes, dementia. So these are this rather practical approach being held by Monash, but also their key priority health areas for First Nations people. And so the guides will support CQRs and governance and data collection and reporting. And so the idea is to prototype these with 3 CQRs and then to scale that up to other CQRs who are interested. So there's the aims of the study is to support CQRs to co-design Indigenous-led governance policies, improve Indigenous data collection and reporting, and ensure culturally safe practices and ethical data practices are also enabled. And we're approaching this across 3 phases. The first phase is around project governance, which has been established. And we've undertaken an evidence review, looking at the literature of what national and international experiences are around embedding Indigenous data sovereignty into CQRs. It's quite scant, to be honest. So it's quite important that we start to generate evidence and information around this. We've also applied for ethics through Monash, so we were able to publish the findings from this to add to the literature. Phase 2 is around stakeholder engagement in interviews and roundtables. So we'll be having key informant interviews with 2 members from each of the CQRs that have been selected, a First Nations member and a non-First Nations, a clinical expert. And then that'll be followed by 2 roundtables. So the first is around getting the perspectives and views of First Nations experts as well as clinical experts around how we can enable Indigenous data sovereignty into CQRs. So we'll hold that. We'll then draft a guide, which will then hold another roundtable to validate and to adjust as required. And so the aim is to finish that by the end of the year with a draft guide. And then next year, over a 6-month period, we'll be pilot testing the guide with the 3 registries to see how it can be operationalised and any challenges or adjustments that need to be made. So the key findings from the evidence review is that there's international momentum around Indigenous data sovereignty, but limited in embedding in CQRs. The main barriers are lack of resources and guidance, institutional resistance. So there's quite often gatekeepers around data, and there's also legislative misalignment. So things like the Privacy Act, that Act, and other relevant legislation doesn't enable that data flow or repatriation to the level that's required, particularly at a disaggregated level. And some of the enablers that has been identified is around Indigenous leadership, co-design approaches, which is essential in terms of ownership and change management for communities and other stakeholders, and the importance of clear frameworks to guide the work. Now, one of the studies that has been conducted around clinical registries was with Ryder et al. Last year. It was published. They audited 107 clinical registries and found that 61% collected ethnicity data, but only 45% identified Aboriginal and Torres Strait Islander status, which is kind of consistent with what Darren also found. This is probably slightly lower. I think Darren, sort of at an eyeball look, it's about 60% that you identified, but this is slightly lower, so perhaps there's been some movement there. Only 7% had Indigenous representation on governance committees, and 12% had Aboriginal Human Ethics Committee approval for the studies involving Indigenous data, which is also a concern in terms of making sure that the research which is conducted reflects the needs and priorities of First Nations communities, and also how it's interpreted and presented, and the narrative that comes out of it has a First Nations lens. So there's a number of CQRs that are actually leading in this space. The ANZIC's CQR has taken the initiative to develop a policy guide for their CQR. The National Cardiac Registry, stroke, dialysis, burns, and diabetes haven't developed any policies, but they have Aboriginal First Nations representation on the committees. So the implications from this study is primarily around many registries fail to represent Indigenous people in data and governance. And again, it's critical for understanding the landscape and understanding the challenges First Nations peoples in terms of those health priority areas. And also, how do we identify those challenges and get that back to the communities who really are the ones at the coalface quite often, providing primary healthcare, but also tertiary in some aspects. So this invisibility affects culturally safe care and health initiatives, and it also sort of highlights the need to embed Indigenous data governance and ethics into CQRs. So stakeholder engagement, so we're engaging with CQR operators, Aboriginal community controlled health organisations, clinicians, researchers and community leaders will be all part of the roundtables. and it'll be co-designed for cultural governance and technical relevance. And this approach was also worked on embedding Indigenous data sovereignty into National Cancer Data Framework. This is the approach we took, and then the end product was kind of really reflected the voices of First Nations communities and leaders in that space, and provides a really clear structure for how to progress Indigenous data sovereignty into different data frameworks. So what does success look like? So CQRs that are technically robust, but also culturally safe and effective. And data supports that Indigenous nation building or rebuilding and health equity. So how can we really get that data back to communities so they're able to mobilise it and use it for their own benefits? So next step is to finish key informant interviews, hold the roundtables, and finalise and pilot the guide by the end of the year. In 2026, we'll be testing the guide. And then we'll deliver a nationally applicable and adaptable CQR guide for long-term change, and scale to other CQRs to enable a nationalised, standardised approach for those interested in progressing in this space. So thanks.
Awesome work. Thank you, Scott. That was perfectly timed, because there's a question here from Megan, which has been asking how the sort of 3 priority areas of cardiac dementia and diabetes were selected, but how will this be expanded in the future?
Yeah, so the 3 areas were selected, about balance of practicality and pragmatism, being a partner with Monash. They're custodians of those CQRs, but also they're highly relevant health priority areas for First Nations communities. And the idea is to prototype it with those CQRs and then provide those guides, draft guides, to other CQRs who may need to adapt around the edges, but essentially they'll have a core guide that they can take on board.
And when do you anticipate the timeframe will be for having, completed the testing and that guide available to CQRs?
Yeah, the project ends mid next year, so the testing will be across the first half next year, and we'll finalise the guide by mid next year, and so that will ideally be available for others to look at and adopt as required.
And are there any other, I guess with that guide, are there any other words of advice that you might have for a registry? Yes, looking at the governance structure of registries and involvement of other cohort groups within that. But are there other people that we should be engaging with?
Well, obviously, NACHO, National Aboriginal Community Controlled Health Organisation, at a federal level, the peak body for community controlled health organisations, will be engaging them through the roundtables. Yeah, and then at a jurisdictional level, you've got the peak bodies for all states and territories. Yeah, so I guess reaching out to them. So what was the other part of the question?
It's really, I guess it's really more around, if I'm running a large national registry, who else, if I want to start thinking about the governance, who else might we have on our governance sort of structure?
Yeah, I mean, my take on this is that at that kind of level, the First Nations people are kind of stretched across, we're quite thin on the ground, unfortunately. So a lot of the time, it's if you have got an existing relationship with First Nations people, strengthening up their data governance capabilities and having them be the main advisors. But essentially, it is about First Nations engagement at that level. So providing on the cultural aspects, particularly, and how data can be repatriated back to community. So across the whole data life cycle, where can First Nations people fit into that? And it's a relational thing as well. So it's not just bringing on the CQRs, it's bringing the whole sector on board, and particularly the community control sector. So those important relationships are also critical.
Yeah, the other point, and I'm just sort of waiting to see whether there are any more questions coming through. But so the other point is that because the primary purpose for most of the registries are around, quality improvement, quality assurance. There are some registries that don't have ethics approval but run under a qualified privilege model. So I guess are there any implications then for them in order to, I mean, I'm going to pick on ANZICS because I know them, but they operate under a qualified privilege model and don't have ethics approval, but they're clearly able to implement their sovereignty and governance.
Yeah, I mean, I think there's obviously the CQI aspect, and that's probably how data can be mobilised as well. So it is a strength in some ways, the agility of that. I think that's why you need First Nations people also on these committees or governance groups, because they can also identify, and this has sort of come out of my first key informant interview, the First Nations representatives on these governance groups are also experts in these spaces, and they can sort of start to lead and determine what the research and quality improvements priorities are for First Nations people. So I think in lieu of having ethics, if you've got a First Nations person who's an expert in that field, then they can really guide the work moving forward.
Fabulous. Thank you so much. Look, really appreciate both yourself and Darren's time today in presenting on behalf of a couple of projects funded by the Department of Health, Disability and Ageing. So, really appreciate that. We've got 3 minutes left, so we're pretty close to being out of time. I just wanted to just remind everybody of those 32 people who are currently still on the call, that we do have the Clinical Trials and Registry Symposium coming up in Melbourne in November, as you can see there. Got some workshops, registry workshops happening on the 18th, and then the Registry Symposium Day on the 19th. There is actually a session in there around equity and diversity, so feel free to register and come along, and we'll see you in Melbourne. And as a final slide, we'd like to really appreciate everybody attending today, and if you have time, if you could actually send through your feedback as well as any ideas about what sort of other topics that you'd actually like to include for future sessions for next year. Thank you very much, everybody.